One of the centerpieces of this meeting has been the announcement of the bundled care that is being proposed by Health and Human Services. And this was a major event that occurred in July. So let me just briefly go through this with you. Department of HHS released a notice of proposed rulemaking, which will be finalized in December, designed to reward hospitals that collaborate with physicians and other providers to avoid complications, prevent hospital readmissions and emergency room visits, and speed the recovery of patients hospitalized for acute MI, coronary bypass graft surgery, or percutaneous coronary interventions. This is a major departure from the traditional fee-for-service scheme, and I think it bears some close attention regarding its details. The bundled payments are designed to foster novel approaches. That's the centerpiece, novel approaches to the coordination of care of these patients during hospitalization and in the 90 days following hospital discharge. The CMS proposes that hospitals enter into financial arrangements with what is broadly defined as other providers, but including cardiac rehabilitation programs, to realize and share any internal cost savings resulting from enhanced coordination of care. So for me, the watchword here is coordination of care, continuity of care. That's what they're after. That's what cardiac rehab can provide. CMS will establish target prices and quality standards to calculate the financial reimbursements to hospital for high-quality, coordinated care provided to patients hospitalized with acute coronary events. Now, what are the implications of bundled payments? I believe that they represent a historic opportunity for cardiac rehab programs to expand their scope of practice, enhance the number of patients they serve, and strengthen their financial standing. However, securing these programmatic and financial benefits will require augmentation and refinement in the traditional methods of cardiac rehabilitation, and that's what my fellow panelists will be addressing today. So to set the stage, why did CMS come to this conclusion? It seems to me that there has been a functional disconnection between the three silos of care, the ED, the outpatient clinic, and the hospital, in which health care is presently delivered. The care provided within each site may be superlative, but prompt and effective communication between silos is often inadequate. To me, this represents one of the greatest growth opportunities in the delivery of care in our time. For example, patients discharged from hospital following these acute coronary events have limited access to telephone consultation with their personal physician or other physicians in the event of an abrupt change in symptoms. They often opt for an ED visit when a brief telephone discussion with a healthcare professional knowledgeable about their medical status, the very essence of cardiac rehabilitation, including cardiac rehab staff, might suffice to alleviate the patient's concern and provide an appropriate alternative to an ED visit. To address the existing gaps in silo-based care, HHS has proposed novel collaborations between hospitals and providers such as cardiac rehab staff who are experienced in the comprehensive management of patients following hospital discharge. So I think we could probably agree that comprehensive cardiac rehab for these acute coronary events encompasses the following elements. First, baseline prognostic assessment during hospitalization and upon discharge, including the results of specialized testing such as exercise echocardiography. Patients at high risk are very likely to be identified early on and removed from the pool because they will be having revascularization procedures. But there's a very large number of patients who qualify as moderate to low risk patients who can properly participate in refinements of cardiac rehabilitation, including hybrid programs and home-based programs. The baseline instruction of the patients regarding coronary risk factor management, pharmacologic treatments designed to alleviate symptoms and enhance prognosis is a keystone of cardiac rehab. Psychological assessment, including self-efficacy training. One of the things that patients can learn within a 90-day period is how to do what they learn in that initial training session. And the question then is, if they master those skills, will they have the greatest benefit of their participation, even if that participation were only for 90 days? I believe there are reasons to believe that patients can be reassured in their own capabilities to adhere to medications and exercise training. Instruction in individualized exercise conditioning, including the use of wearable monitors. Fitbit and Garmin are now our proxies in the world. There are many people who rely utterly upon them for stimulating their physical activity. But importantly, to record the frequency and duration of exercise bouts so that a patient participating at home exercise will have a quantifiable measure of their dose and duration of physical exercise training. Symptom recognition and management, including provision for prompt reporting of a change in symptoms to cardiac rehab or other healthcare professionals. This is fundamental. We say to our patients who are involved in these various programs of care management, call us early in the week, call us early in the day. If you call at 5 o'clock on Friday afternoon, you likely would have had symptoms a few days or hours before then. Call us as soon as you recognize a change in symptoms, and if it's nothing, we'll reassure you. If it's something, we'll be able to act on your behalf. Ongoing reassessment of patients' medical status and treatment program over the course of their participation in various variations on cardiac rehab are fundamental to providing liaison with patients' physicians and hospital physicians as needed. Now, this implies that there will be a new collaboration between the hospitals and cardiac rehab. Medicare didn't choose the hospitals simply by random choice. Hospitals are an increasingly powerful force in American medicine, and they have, in my experience, closely approximated, if not exceeded, the power of the insurers. They are major players. They will get the picture here in terms of the potential benefits to them. But managing that collaboration will involve assessment of the process of care, the frequency and type of interactions between patients and cardiac rehab staff concerning visits, telephone contacts, et cetera. This is relatively straightforward. It represents the effort involved in managing patients by this method. Assessment of the outcomes of care are also fairly straightforward. Patients' symptoms, their functional status, their satisfaction with care, the frequency of urgent care and ED visits, and the frequency of hospital admissions. This is part and parcel of what hospitals do. They manage those kinds of data. I think they'll understand the opportunity that is presented to them. And then documenting the value of enhanced cardiac rehab services. Patients' well-being and satisfaction with cardiac rehab services is paramount. Symptom control, and the frequency of ED visits and readmissions. There are two ways to change the care that patients receive and the outcomes they experience. One is to focus on the biology, and this takes more than 90 days affords in terms of exercise training over a long period of time, which undoubtedly establishes a prognostic advantage. But also the frequency of ED visits, readmissions, and physician satisfaction with cardiac rehab's role in the ongoing management of their patients. So I think these are relatively straightforward parameters, and they can guide our discussions. Distribution of the financial benefits resulting from coordinated care, or what I like to say is enhanced cardiac rehab services, would represent the gross savings resulting from coordinated care and fewer ED visits, rehospitalizations, et cetera, minus the programmatic costs of providing coordinated care through visits, telephone contacts, and so forth. And the difference between those represents the net savings to be shared appropriately by hospitals and cardiac rehab programs. Now, we're at the very beginning of this process. We won't know the details until December, but my sense is that hospitals will embrace this opportunity, and as long as the programs that are being offered are efficient and effective, I think that they will endorse them.